طيب الفيرست سبيكر بالسيشن راح يكون الدكتور أيمن حمدان. موضوعه كتير راقي ورائع. Heart failure in acute coronary syndrome patients. مش هذا موضوعك؟ دكتور أيمن.
Thank you.
Heart failure in acute coronary syndrome patients. ما بدوش يجاوبني.
And I'll be, inshallah, quick because I know it's late. I'm not giving a typical heart failure lecture, truly. I'm just going to talk about the impact of heart failure. In the world, we have close to 64 million people who suffer from heart failure with an economic burden of more than $346 billion. We like to quote statistics from the United States because they have probably some of the most accurate stats. They have, in a population of between 320 to 340 million people, they have 6.7 million people who suffer from heart failure with an annual cost per patient between $30,000 to $40,000. There are 4 million people who die from heart failure each year globally. 700,000 people died from heart disease. That's equivalent to 1 in every 5 deaths. The global burden is close to 400 billion per year in direct medical spending and indirect costs such as loss of productivity. From the Framingham Heart Study, the mortality rate after the patient is diagnosed with heart failure was in the first month 10%, climbed to almost 30% in the first year, and up to 60% in 5 years. That's really a prognosis worse than some of the cancers. And myocardial infarction, we stress, remains the most common cause of heart failure worldwide. And for almost 50 years, heart failure has been recognized as a determinant of adverse prognosis after myocardial infarction. The primary PCI has driven improved early survival after myocardial infarction, but its impact on the incidence of downstream heart failure is still debated. The effect is confounded by changing epidemiology of MI and heart failure, aging population, and increasing proportion of non-ST elevation myocardial infarction. Heart failure is a major cause of late morbidity and mortality after MI, and several approaches exist for early identification of patients' risk of heart failure, including the clinical and angiographic scoring, cardiac imaging, and invasive coronary physiology, but these are currently poorly integrated. The primary PCI has really revolutionized the management and the outcome of myocardial infarction. It is the reperfusion strategy of choice throughout the developed world, close to like 1 million procedures in the United States alone, 3 million worldwide. In the United Kingdom, PCI door-to-balloon time is done most of the time below 60 minutes through the radial axis with second and third generation drug-eluting stents and the tailored use of antiplatelets and antithrombotic agents. And the introduction of the primary PCI and the adjunctive therapies have really driven a reduction in the inpatient mortality following acute MI from 20% to a single digit. But despite the success, coronary artery disease still remains the most common cause of heart failure. Heart failure post-MI is a major driver of late morbidity, mortality, and health care cost. The targeted therapies to prevent heart failure after MI has really lagged behind advances in the reperfusion. But with the introduction of medications like Entresto and the SGLT2 inhibitors, we are hopefully making a progress. As we know, heart failure is really a clinical syndrome resulting from many structural or functional cardiac disorders that impair the ability of the ventricles to fill or eject blood. There is no universal definition, and consequently diagnosis is often heterogeneous between studies and over time. There are 3 key time periods need to be recognized or distinguished: heart failure at index MI presentation, or during the course of the first admission and after discharge. Of course, several overlapping mechanism contributes to heart failure after MI. Heart failure during the acute MI index occurred due to the combination of myocardial stunning, myocardial or myocyte necrosis, or if the patient has a decompensation of a pre-existing heart failure or acute mitral regurg or secondary to papillary muscle dysfunction. Now, during the hospitalization, it also may be due to any of what we do as physicians, like given too much fluid or contrast overload, renal dysfunction, or a complication of ventricular septal defect or cardiac tamponade. The late heart failure reflects the consequences of cardiomyocyte death and scar formation occurring alongside ventricular dysfunction. We know within 30 minutes of ischemia, the cardiac muscles has structural changes in the form of edema, enzyme leak, and beginning of cell death, which happens really from 3 hours on. That's why time is very important. Now, prior to thrombolysis, the incidence of in-hospital heart failure after ST elevation MI was around 40%. There appeared to be reduced after the introduction of thrombolysis, 3% of the patients and 17 during the admission. Heart failure during admission remained an adverse prognostic feature with 1-year mortality rates approximately 5-fold those who do not have heart failure. Now, the lifetime cost, each patient costs between $300,000 to $400,000 because now he's going to be from an independent to a dependent person who might support his family with the cost of follow-up, with the cost of medication, and recurrent hospital admissions. In contrast, data from Framingham Heart Study shows an increase in heart failure over time. Now, that could be due to now people who are having heart attacks are being saved, so they live longer. Our interventionalists are more gutsy now, and they start treating more frail and elderly patients. Just a quick one, it doesn't really begin or stop by just an MI. If the patient has high blood pressure and we manage to reduce his blood pressure, a reduction of 10 millimeter in systolic blood pressure can translate to a 20 or 30% reduction in the incidence of major cardiovascular events, myocardial infarction, and don't forget stroke, because stroke is really probably number one cause disability among many of these conditions. And a reduction of 5 millimeter in diastole could translate to a 25 reduction in the risk of coronary artery disease. And when it comes to heart failure, a 10 millimeter reduction can lower the risk of heart failure by 20 to 30%. I'm just going to skip this for the... I could just give you an example that all of us are at fault. The community, the doctors. Like if we have, for example, if there is 100 people walking in the street who have high blood pressure, half of these people don't know they have high blood pressure. So 50% of the population doesn't know he has high blood pressure. And out of those 50%, maybe 60, 70 will go to the physician, to the doctor. And out of those 50% will be treated, and out of those 50% will be treated to the standard guideline. يعني من كل 100 بيمشي بالشارع بhigh blood pressure, we are treating 10 to 12 out of them. So it's not enough just to give the patient the medicine. And I've been practicing here for 2 years, and what shocked me is people think hypertension is like flu. زي الواحد المرشح باخذ الدواء شهر بقيس ضغطه بقول لك ضغطي ممتاز, and he leaves it. So we really have to stress on the importance of public awareness. I had a question on the lecture before. Is okay, the EMS comes to the patient within 7 minutes. I don't see anybody in Jordan on the street making way to the ambulance. الامبولانس بيكون ويزمر واحنا ولا حدا فاتح له الطريق. So he could get to the patient in 7 minutes, and he needs 2 hours to get to where he's supposed to go. Thank you so much.
Thank you, Dr. Ayman. نأجل الكويشنز لنهاية السيشن. الدكتور محمود زريق is the next speaker. He is going to talk about ECG in the emergency department. دكتور محمود تفضل.
شميت السيجنال. مرحبا، الله يعطيكم العافية. أكيد الطلاب والمقيمين بيستنوا فيه بالمحاضرة، صح؟ يعني أكيد الكل تعبان ودايخ. بنحاول نعمل انتر اكتف نوعا ما. طيب، هو البرزنتيشن هو راح يكون عن acute coronary syndrome in the ER. وراح نحكي عن ST elevation، عن الهايبر acute T wave، ST depression، T wave inversion، left band branch block مع acute MI، وبسموها ignored AVR. هاي جديدة، مصطلح جديد وصرنا نستخدمه، راح نحكي عليهم واحدة واحدة. بس before that أنا عامل كرتون، هاي عاملها قبل حوالي 20 سنة. The most common cause of MI is plaque rupture. طبعا في other causes، في erosions، في mismatch، بس the most common cause. بعطيكم الكونسبت تبعها. عادة بصير في crack بالشولدرز، بعدين بصير عندنا platelet adhesions، platelet aggregations and thrombus formation. إذا سكرت كاملة بنحكي عليها ST elevations MI. إذا كان partially ممكن يكون non-ST elevations MI or unstable angina. بس هذا الكرتون حتى تفهم الكونسبت تبعها. في سؤال كتير مهم وفي أخطاء شائعة فيها خاصة للمقيمين للطلاب. What's the point of ST elevations؟ كيف إحنا بنعتبر إنه بنحكم إنه في ST elevation point؟ مثلا هذا الإكزامبل point A B or C. What do you think؟ مين مع ال A؟ مين مع ال B؟ مين مع ال C؟ excellent. هو عادة هو نقطة لقاء، يعني عادة the point of J points اللي هو ends the ends of QRS complex and ST elevation and the ST segment starts to elevate. هاي بعطيكم an example إلها وهي كتير مهمة. طيب خلينا نعطيكم كيس. 65-year-old female patient. She presented with chest pain, 2 hours duration, troponin negative. Past medical history, she is diabetic, type 2. Past medical history also TIA, blood pressure borderline. And this is the ECG. What do you think? There is a significant ST elevation in V2, V3, V4, V5. This is anterior MI. طبعا هدول المرضى عادة احنا شو بنعمل لهم؟ نعطيهم ثرومبوتيك ثيرابي ولا بنوديهم على الكاث؟ طب ليش ما نعطيهم ثرومبوتيك ثيرابي ونرتاح؟ وجع الراس هذا واضرب واطرح وبعدين بده الكوست تبع الكاث والشبكات، نعطيه إبرة الحياة هاي ونخلص من الموضوع. What do you think؟
مش موافقين لا.
طيب بس اعطيكم الكونسبت يمكن الدكتور مصطفى حكاها بالبرزنتيشن. To open up the artery by thrombolysis about 50%. Depend إذا كان streptokinase 50%, TPA 60%. To open up the occluded artery by a cath lab by PCI more than 95%. For that reason احنا بنحبذ انه المريض هذا as soon as possible ندخله على الكاث لاب. السؤال الثاني اللي بنطرح، مين أسوأ؟ الانتيريور ماي ولا الانفيريور ماي؟ What do you think؟ مين بيحكي inferior ماي؟ 1 2 3 4 5 6 7 8 9. مين بيحكي anterior ماي؟ أقل أنا شايف.
أنا بقول anterior.
قطعا الانتيريور ام اي، لأنه البلس سبلاي للانتيريور ام اي للفنتركل 2/3 of the ventricle supplied by left system by LAD. For that reason اختار دائما الانتيريور ام اي. هسا في كونسبت، هاي المريضة بعطيكم اياها، طلعوا توتال مسكر كامل. هاي الليفت مين، هاي ال اي دي توتال مزبوط، وهاي سيركمفلكس. طبعا هذا بده فتح، بس هذا المريض واحنا عم نعمل له الانترفنشن صار عندك كارديك ارست، وهذا أسوأ شيء بالكات لاب. أسوأ شيء وبالكات لاب وانت عم تشتغل المريض كارديك ارست. شوف كم واحد عم بيستناك برا، شوف الشعور تبعك والاسترس اللي عندك. طبعا فتحناها احنا. طبعا هذا بوست افتر ستنت ديبلويمنت. المريض كان ايجكشن فراكشن 20%. في شغله كثير مهمه بسموها ستاند مايوكارديوم. Do you know what does it mean ستاند مايوكارديوم؟ شفتوا اللي بيلعبوا كفوف بين بعض، اللي بتضرب كف للثاني، هاي لعبه رياضيه، بصير في عنده بدوخ، صح؟ زي المضروب على راسه. نفس الشيء هون، او الدجاجه المضروبه على راسها. نفس الشيء هون. الستاند معناته لما يصير في عندنا كات اوف بلاد، العضله حتى يصير عندها ريكفري it takes time. could be seconds, minutes, days. احنا عاده بنعتبر up to 1 month. اذا كان من ل 1 month after 1 month و still low ejection fraction then احنا بنفكر نعطي للمريض نحط لهم اي سي دي. طبعا هذه المريضه دخلت ب ejection fraction 20% after 1 month 45%. طيب what do you think about this ECG? 6-year-old male presented with epigastric pain. You look at lead 2 ST elevation, lead 3 AVF, وعندنا ST بالlead 1 and AVL ST depression. What do you think? This is inferior MI. السؤال اللي بحكيه بالطوارئ، إذا إجاكم مريض عنده inferior MI you should go for تاخذوا leads على right side. Why? To rule out right ventricular infarction. Why? Nitrates is contraindicated in this case. وهدول المرضى عادة احنا بنعطيهم fluids قدر الإمكان. Fluids and fluids and fluids. هذا كيس هي واضح جدا inferior MI أخذناه على right side في ST elevation. الباسيور posterior MI تذكروا انه في عندنا بكون في عندنا ST depression in V1, V2, V3 and positive are in those leads. هذا this is a real case. هاي الحالة من الجامعة الأردنية. Correct.
عيدها على ابو قيس عشان الجونيور اتند.
Even though انه طيب
مين بيعملها بس
هاي جايد لاينز ولا هاي بيرسونال اوبينيون ولا اكسبرت اوبينيون ولا جايد لاينز؟
ما اختلفنا بس before deciding whether to give or not to give. يعني تعمل له it will bleed posterior back posterior
V7 V8 V9.
انت you have to go 7 8 9 if there is an ST elevations or mirror shape بكون احيانا موجوده.
هم
بس you confirm that you have 7 8 9.
على اس depression in V1 with dominant R خلص this is enough.
طيب.
بس هلا انت sometimes you can get ischemic pain while the ECG is normal then you go for 7 6 and 9.
طيب احنا لا بلاش نناقش نقاش فرعي، خليها لانه الموضوع طويل عندنا. This is a real case. هاي من الجامعة الأردنية. This is what do you think about this ECG? هذا المريض بس أعطيكم قصة. هذا دخل عيادة الجامعة وعمل إيكو نورمال. عمل ECG نورمال. عمل ستريس تيست for 10 minutes نورمال. نزل تحت على الطوارئ نفس المريض. نزل تحت حتى ياخذ العلاج تبعه في دور طويل. صار عنده cardiac arrest and this ECG. What do you think about this ECG? شباب المقيمين. This is wide complex concept. يحكوا wide complex tachycardia. This is rule number 1. Once you have مريض loss of consciousness وعنده wide complex tachycardia, This is VTAC until proof otherwise. What is rule number 2? مين بيعرف؟ أنا كنت أحكيها دائما هاي. إحنا حكينا if you have wide complex tachycardia مع cardiac arrest, this is VTAC until proof otherwise. This is rule number 1. What's rule number 2?
No, there's no rule number 2. مش rule number 2.
لا في rule number 2. وهذا written كمان بالامريكان هارت اسوشيشنز تعليق صغير عليها. ايش؟ Remember rule number 1. How it's significant. ما تقعد تفكر بشيء ثاني. This is VTAC. ماشي الحال؟ بس بدي اورجيكم الكات تبعه.
طب شو rule number 2؟
Remember rule number 1.
ما يلحق.
Rule number 2. Remember rule number 1.
على فكرة ضلك 5 minutes شو ما
طيب.
كان. rule number 1 ضلك 5 minutes.
اطلعوا على What do you think about this ECG كات؟ هذا المريض نفسه. اطلعوا. It is almost clot, big clot على الليفت مين. ال LED مسكر والسيركمفلكس almost رايح. هذا نفس المريض. طبعا المريض هذا دخل ونعطى له اجروستات وهيبرين والى اخره وبعدين نعمل له PCI.
يعني
What
هذا
is
he was
this?
stressed for 10 minutes بدون symptoms
بدون symptoms.
وهي developed this clot بعد الستريس
Yes.
تيست.
Yes.
بعد الستريس تيست.
Yes.
اوكي.
Yes.
عشان تكون واضحة بس يعني.
What do
You
you think
cannot
about
exercise 10 minutes مع الكلوت هاي يعني.
يعني صار عنده plaque rupture.
Yeah.
What do you think about this ECG? This is a 72-year-old. أنا هذا كان لما كنت في مستشفى أعمال جراحي. 72-year-old. She presented with chest pain. What do you think? Concentrate على V4, V5.
acute T wave.
هاي بنسميها hyperacute T wave. What is the definition of hyperacute T wave? You should have amplitude 10 millimeters in pericardial leads and 5 millimeters in limb leads. حتى نحكي عليها this is hyperacute T waves. What is the differential diagnosis? Three important differential diagnoses. طلعوا عليها. Could be hyperkalemia, could be hyperacute ischemia, could be normal. اطلعوا له على الهايبركاليميا عادة شو بتكون؟ symmetric, narrow based, tinted. زي ايش؟ pointed. زي ايش؟ حدا بعطيني مثال عليها؟
منقار.
غير الخيمة، غير المنقار،
منقار.
غير الهنجار والمنقار. زي الخازوق. ما تزعلوا مني.
خلص
يعني
thank-
أكيد
شكرا
إحنا-
دكتور محمود شكرا. المحاضرة انحرفت عن مسارها.
طيب. يعني مبوز هذا لازم تذكروها. طيب hyper acute wave عادة symmetric broad based not tinted. هذا بالاسكيميا. اما بالنسبه للنورمال فاريانت عاده بتكون asymmetrical. خلينا نعطيكم مثال. What do you think this case?
evolving
tinted,
anterior.
pointed ولا broad?
evolving anterior MI.
هذا this is ischemia. This is ischemia. What about this one?
هاي بيك.
This is hyperkalemia. مبوز. ها؟ طيب. What about this one? This is hyperacute wave due to ischemia, acute MI. هو نفس الشيء عندك hyperkalemia. هسه بنحكي على diffuse ST elevation. Diffuse ST elevation, one of the differential diagnoses بالemergency room, you should think about acute pericarditis. Acute pericarditis. عادة بتكون بكل الليدز except in V1 and AVR. Sometimes في عندنا ST segment elevation in V1 and AVR. وpathognomonic لما يكون في عندنا PR segment depression. Left band and branch block and acute MI. هسا أي مريض هو كان with chest pain وما عنده previous ECG أو كان ال ECG normal جايك بليفت باند branch block considered as إنه هذا acute MI and should be managed as ST elevations MI. هاي examples عليها. هسا في شيء بنسميه احنا سكاربوزا كرايتيريا. سامعين فيها سكاربوزا كرايتيريا؟ في 3 كرايتيريا نسأل فيها is there is ST segment elevation more than 1 millimeter that concordant with the QRS complex takes 5 scores أو is there is ST segment depression more than 1 millimeter in leads V1, V2 or V3 3 scores. السؤال الثالث is there is ST segment elevation more than 5 millimeter that is discordant with the QRS complex تاخذ 2 score. احنا عادة more than 3 scores بنعتبرها positive. هسا وين مشكلة الكرايتيريا هاي؟ الكرايتيريا هاي السنسيتيفيتي تبعتها low. It's about 20%. السبيسيفيسيتي تبعتها high. More than 90%. 98% around. البوينت تبعتها it's not sensitive. طيب. نعطيكم بس other example لما يكون في عندنا T-wave inversion including V1, V2, V3, V4 هذا شو بنسميه احنا ويلين ساين. عادة بكون عندنا proximal LAD lesion ها يا بكون عندنا هو بنقسمه لقسمين ويلين ساين A ويلين ساين B يا بكون عندنا biphasic T wave او بكون عندنا symmetrical T wave inversion. denotes انه في عندنا proximal LAD significant lesion. هاي this is an example. This is a biphasic T wave واضحة بال V1, V2, V3, V4
مع كيوز.
and this is sometimes ترى دير بالكم الاسوشيشن مش بس بالليفت باند برانش بلوك مع الرايت باند برانش بلوك and this is the case with right band branch block ST elevation V1, V2, V3, V4. السؤال اللي بنسأل does normal ECG rule out acute coronary syndrome? The answer is no. حدا بعرف لو جينا مثلا normal ECG what is the percentage انه يكون المريض عنده problems بالكورونري؟ 40 to 50%. 40 to 50%. أعطيكم example. هذه 36 year old female لا هذا 36 year old female heavy smoker presented with left-sided chest pain almost normal ECG right? heavy smoker بالمناسبة. اطلعوا بالله بالاي سي جي بالكاث شايفين المنطقة هذه عنده 99% LAD lesion واضحة هاي بالصورة هاي المنطقة هاي. المريض everything is normal حتى الإيكو ما في عنده area of hypokinesia it's normal. طبعا هذا بدل لك انه this is LAD 99% stenosis هذا post stenting. ها there is no family history heavy smoker بتدخن 3-4 باكيتات في اليوم. ايش هو؟ والله unlikely spontaneous dissection. ايش هو؟ smoking yeah 3 packs per day. حطينا له هاي ستنت وبيوتيفول يعني. طيب
محمود
هذا ايش في وقت؟
شو خلص 1 minute اظن عديت 15 minutes حسين.
ما هو احنا في ناس غايبين مش هيك خلينا اقدم
غايبين اعطوك حصتهم غايبين في راوند تيبل ديسكشن لسه.
الدكتور حجيري هون
محمود احنا مستمتعين بس اختم
زي ما بدكم بس انا اعطيكم بس اخر كيس على الاي في ار اس اليفيشن ريال كيس عندي. طيب بعد اذنك دكتور اياس
اذنك معك تفضل.
احنا دائما بندعمك دعمنا المره دي.
ابشر.
هذا 65 year old male هذا اجاني وانا على الساعه حوالي 1 بالليل presented with atypical chest pain echo showed good LV with severe mitral regurg x-ray كان early pulmonary edema and this is the ECG. أنا البوينت بدي أورجيكم على ECG في ST depression lead 2 lead 3 تطلعوا على ال AVR and V1 there is ST elevation. هاي اللي بنسميها احنا the ignored AVR. Once you have ST elevation in V1 and AVR معناته في عندك significant lesion could be this proximal LAD circumflex or left main. بس هذا طلع بالكاس شو طلع عنده؟ unbelievable ها clot big clot involving left main, LAD, circumflex. ايش؟ مريض yes. والله unfortunately he died. We could not يعني هسه بس احكي لكم انا البوينت هذا المريض عنده severe mitral regurg. انا I consult الجراح اللي موجود كان and he decided to do surgery for him. ودوه على الجراحه and he died there.
في structural mitral
Severe.
لا يعني انه ischemic ولا
والله you cannot judge them انه عنده من اول ولا this is prolapse ولا this is from the ischemia could be.
left atrial size
بس severe يعني
left
الفنتركل
atrial size.
كان نورمال بتقولي صح؟
الفنتركل yes normal.
الفنتركل نورمال
Most likely this is acute.
papillary muscle
لا.
This is
لا.
acute
ischemia or rupture.
لا. طيب الله يعطيكم العافيه.
شكرا محمود.
شكرا. إذا أخيرا last talk will be لصالح الدكتور محمد الحجيري. نسمع شوية كهرباء من الدكتور محمد. وينه؟ جايب الأزرق. دكتور محمد الحجيري will talk about unrevealing electrophysiological complications of acute coronary syndrome.
Thank you very much. Thank you for inviting me, and this is a great conference. It's going to be much shorter.
شوية لك وقت.
أنا سريع. All right, so we'll talk about the ventricular tachycardia part and prevention of sudden cardiac death. A quick run-up, ventricular tachycardia is when you have 3 consecutive complexes originating in the ventricle at a rate of more than 100 beats per minute. So 3 PVCs in a row is considered a VT. Sustained VT is when we have more than 30 seconds or requiring termination due to hemodynamic compromise in less than 30 seconds. So VT with hemodynamic compromise is considered sustained VT. VT for more than 30 seconds with no hemodynamic instability is still considered sustained VT. Non-sustained, anything else, more than 3 beats. The monomorphic is that the QRS is stable, polymorphic coming from different places, and bidirectional is 1 positive and 1 negative. So it's important that of all the out-of-hospital cardiac arrests, more than 50% will have significant coronary artery lesions in acute coronary angiography. So what does this mean is that sometimes the acute STEMIs, they don't necessarily present with chest pain, they can present with VT. So VT is an important presentation, can be either it can be a presentation of acute ACS. Of the patients hospitalized with acute MIs, 5 to 10% have VF or sustained VT prior to hospital presentation, and 5% will have VF sustained VT after hospital presentation. So there was this Danish study of 11.6% of patients with ST elevation underwent PCI had VF prior to the PCI. And then we'll talk to you a little bit of some real cases, ventricular tachycardias of ischemic VTs, which means they are related more to the to ACS and coronary artery disease. So this is a gentleman who had known sustained VT and had an ICD with ischemic cardiomyopathy and a HFrEF ejection fraction of 35%. And he had recurrent admissions in the ICU and the CCU. The patient presented to us with, presented initially to an outside hospital with an acute coronary syndrome and VT storm, and there was an endocardial VT ablation. That was done. Initially, there's a video. That's the first case. The second case I wanted to, and then we'll show you the videos. The second case is this lady who also had an ICD for secondary prevention after ischemic myopathy with acute MIs, who also came in for, I think there's a video that is missing. There it is. Okay. So this is the first patient, the first patient who was ischemic myopathy transferred to us after having an endocardial. He, after presenting with acute MI, he went into sustained VT and his ICD shocked him 89 times. And he was transferred to us from Irbid. And this is, let me see if this works. appropriate shocks for sustained ventricular tachycardia. So what I'm showing you here is basically, I just want to pause it. Okay, it's going to run very quickly. This was 9 hours of mapping and ablation that we're going to put in 1 second. So technically what we're doing is, because of the sustained VTs, and he was shocked 89 times, we brought him in for VT ablation. And what you're about to see is a 3-dimensional map of the ventricular tachycardia. And this is the, what's red is dead and it's bad. And what is purple that you're going to see is good. It's normal tissue. And let me just run this so that it will show you what's left of the normal tissue. بس بدي أعمل play للفيديو please. مش عارف أعمل play. 89 times. He needed a generator change after that. So you can see the extensive damage from his coronary artery disease. What's left is only the purple part, and everything else is just messed up. And the VT was coming from the inferior wall, and that's the inferior wall of the ventricle, and that's where we were ablating. What's left is literally only the purple part. This is the left ventricle, and that's the only part that was technically moving. Everything else was just messed up. So this is another view of that same patient. And then now let's go back, let's go back to where we left off. Okay, so that was the first one. We have another patient who presented with also multiple ICD shocks, 35 ICD shocks for this patient. This patient underwent initially endocardial VT ablation, but then she continued to have a VT storm and then ended up having epicardial VT. So we went back and we went epicardially, and then we ablated her from the epicardium. This is the initial presentation of the ECG. This is VT, obviously. Whenever, and for whomever is here and still in their training, if you see this and you think it's SVT, then obviously there's something wrong. This is definitely VT. If you look at, if you find a negative in V1, always suspect epicardial focus. I saw her afterwards after the endocardial and the epicardial VT ablation, and she was still doing well, no VTs, no evidence of VT. The patient from Irbid, that was 1.5 years ago, I saw him just 2 weeks ago, and he was VT free completely. He was doing very well. He's actually a professor at the university there. So let's talk about ventricular arrhythmias in patients with ischemic heart disease. It's probably the important part that we're going to include in our guidelines. حط لي اياها بالله على السلايد رقم 14. Thank you. Okay, so treatment of recurrent ventricular arrhythmias in patients with ischemic heart disease. In patients with ischemic heart disease and recurrent ventricular arrhythmias with significant symptoms or ICD shocks despite optimal device, programming and ongoing treatment with a beta blocker, amiodarone, or sotalol is useful to suppress recurrent VAs. And let me actually talk about the class 2Bs and the class 3. The class 3, it is harmful in patients with prior MI, class 1C antiarrhythmic medications, flecainide and propafenone. And I mean, we don't have flecainide and propafenone, but I have seen patients with significant coronary artery disease being placed on propafenone and flecainide. So class 3s are very important to know just as much as the class 1s. The class 3, another one is when we have incessant VT-VF, an ICD should not be implanted until sufficient control of the VAs. And this is a question I usually get where when somebody is having recurrent VTs, and then the family thinks that if you put an ICD, then if you implant an ICD, then that's going to make it go away. It's not going to go away. In fact, it's going to make it worse because that ICD is going to keep shocking him. So that is a class 3 recommendation. And then there are things with no benefit. In incessant VT storms, it is a class 1 indication to do a VT ablation in patients with VT storms. So if we're going to talk about the Jordanian guidelines in management of sustained VT. So if we have sustained VT, if we have a pulseless VT, then this is probably, we just follow the ACLS protocol. If we have VT with a pulse and we have hemodynamic tolerance, Based on that, whether it's tolerated or not, if the patient has hemodynamic intolerance, then we also need to look into this. With VTs, if you have, and our colleagues talked about non-STEMIs. So if you have a non-STEMI and the patient is having no chest pain, and you're saying that you want to cath this patient tomorrow. But one of the indications where you should cath the patient soon is that if that patient is having VTs. So if you have a VT, even though if they're having no chest pain, you don't want to delay the non-STEMIs. The STEMIs, we all agree on that they need to go right away, but this is not something you want to do that. So in unstable VT, exactly what Dr. Mahmoud was saying is like you shock. You just go follow the ACLS protocol and then you shock and assess pulse and hemodynamic stability. Again, in stable VTs, it is okay, and you won't hear me say that a lot about using amio, but this is where I always use amiodarone. Amiodarone, you want to make sure the rhythm is restored. You keep using as much as amio as you can, and then you admit to the CCU if they're stable, and then you have to go back and make sure the patient is cathed. The cath is very, very important in these patients. If you terminate the VT, yes, that's great. You continue to follow the guides, and if not, then you go back to amio. If it doesn't work, you go to Lido. Lidocaine is also very, very helpful, and thankfully, we actually have it. The other thing is that in patients with ICD shocks, if somebody has an ICD, or if you're having VTs and you're unable to stop the VTs, intubation is a great way to try to stop the VTs. It's just that, and it's also one of the ways that if your patient is having ICD shocks, intubation is a merciful way, because this is a very, very painful, especially if they don't go into VF. So VF will make them pass out, so they will not feel the shock. It's more dangerous, but they will not feel the shock. But if they're in sustained VT, that ICD is going to keep shocking them. They're going to go to sinus, and then if you have a focus, then it's going to go back and shock them again, and shock them again. And if that happens in the intractable VT, at some point, we would recommend referral to a tertiary VT center where a catheter VT ablation can be done. And this is a class 1 indication. So, if amio and Lido, they don't work, intubation. Intubate the patient. I don't have that much experience with it. From the US, I don't think I've used that much, but I don't have that much experience. So the VT tertiary centers are limited, but VT is done at the Royal Medical Services, VT ablations. It's done at Abdali in our center. So I think that it would be efficacious to do that. We would recommend transferring the patient to a tertiary VT center if we're going to call it a VT center. We all know the effects of amiodarone, but in this case, we can use amiodarone. It's okay. And if you start having problems with amio, then you can drop it to 100 milligrams. But obviously, a VT ablation, if offered and done correctly, then the patient will do very well. It is like a pact with the devil. You win some, you lose some. Thank you very much.
شكرا دكتور محمد يعطيك العافية.
في أي أسئلة؟
I think في مجال لأي أسئلة؟ في مجال محمد سمحنا بدقيقتين محمد.
ده؟
دكتور أيمن تفضل. دكتور محمد تفضل. دكتور محمد. A lot of the times we forget the potassium. We have to really correct all these electrolytes.
Yes, we have to follow the ACLS protocol, and one of those is just absolutely the electrolytes. And then, because if you have somebody with hyperkalemia, but unfortunately for the interest of time, couldn't all connect it in here. But if we put it part of the ACLS kind of, or you always have to, the 5 H's, the hyperkalemia and all that, this is extremely important in when it comes to this.
Thank you, Muhammad, for such a great presentation. And actually, I want just to agree with you 100%. And the fact that if you have a incessant VT, intubating them and putting them under sedation actually does work. And we had a case in Jordan University, actually, not too like a couple of months ago. We've tried everything, high dose amiodarone, lidocaine, and nothing would break it. Repetitive shocks due to the ICD. Once we put the patient under anesthesia, or sedation,
it stops.
stopped
It's beautiful.
completely, and then Dr. Munir
You
actually-
wake them up, it comes back.
Yes, yes. So it does work. Actually, it does
Yeah.
make. Yes.
Yeah, it's
No,
interesting.
we had to, of course, do the ablation while she was intubated and sedated. Go ahead.
Thanks, Mohammed. I enjoyed your lecture. Sometimes we send our patients post-MI with low ejection fraction after full medical management, and we get some rejection from the government services that they are not candidates for AICD. So what is, in your practice, post-MI ejection fraction that you will say that patient needs an AICD? Not
So-
CRTD, AICD.
Yes, so if we just follow the guidelines in ischemic, it's ischemic. So if you don't do anything for somebody who's had an MI and you find that this is a late presenting STEMI, by guidelines you have to put an ICD within 40 days, after 40 days, if the ejection fraction has not improved. In ischemia, if you actually intervene and you put a STEMI and you put a stent in there, then in 3 months it becomes just like non-ischemic after GDMTs with beta blockers, the 3 beta blockers for heart failure, which is bisoprolol, metoprolol, succinate, not tartrate, and carvedilol, in addition to Entresto or ARBs-A's, in addition to eplerenone and SGLT2 and pagliflozin. In 3 months, if they improve to an ejection fraction above 40%, you don't have to put an ICD. But from my practice in Jordan, there is a variation in terms of calculation of the ejection fraction. So there's so we see patients where the ejection fractions has technically improved to 45%, let's say, but then with another measurement is in the 30-something%. By guidelines, if it's between 35 and 40%, you need to do an EP study, and then the EP study can decide whether you go in an ICD, you get an ICD or not. And if it's less than 35%, then you put an ICD. However, this calculation, there is a variation from my experience in terms of calculation of the ejection fraction. So sometimes if I am in the dark, I just order an MRI, a cardiac MR, to help me exactly give me an accurate calculation of the ejection fraction to make sure. One is that if they don't need an ICD, you don't want to put an ICD, but if they do need an ICD, you don't want them dead in a year or two. So that's basically it, and that's not looking at that is assuming the QRS for the patient does not have a QRS above 130 if it's left bundle branch block, or above 150 if it's right bundle branch block. And that's basically whether, if it is, then a CRTD is reasonable. Now going back to Jordan, is that if you want to put a CRTD in a patient and the ejection fraction and the left bundle, let's say, is 120 milliseconds or 119, but then for financial reasons, these people, if the left bundle becomes in a year or two, if it becomes 150, 140, and then at that time you need to upgrade to a CRTD, it's not very possible financially in Jordan, because once they have this device, they're already collecting. It's a lot of money. It's thousands of GPs. So, but that's basically the rules for implanting ICD.
Just silly question. Is there a limit in an age limit for the guidelines or comorbidities that's limiting the life?
No, there's no age limit in the US, as Ayman knows. If you have 90-something-year-olds.
What is cancer disease or something that's limiting his life expectancy?
Yes, if you have cancer, metastatic, and if your prognosis is less than 1 year, then that's a different story. But for the age limit, there really isn't an age limit, but generally it just becomes a discussion with the family, where you want to tell them that, do you really want this ICD, do you really want to do, so it's just, and even Jordanian families, they are receptive to that. It's sometimes not really reasonable to put a CRTD in a 90-something-year-old, because you're going to, whereas a pacemaker is a bit different, because a pacemaker, the patient is syncopizing and they're just extremely tired, so pacemaker becomes a matter of a lifestyle.
Beta within now 72 hours, when in mind is something.
48 hours is just you ignore it. So if you have post perfusion, if you've a patient comes to you with a STEMI, you put a stent, and then within the first 48 hours, you still have 24 hours, you still have some VTs. You just keep an eye on it, and just don't necessarily mean you have to put an ICD. Obviously, VT before the STEMI, you don't put an ICD. It's sudden death because, but you have to also use the common sense in a way. Your better judgment, because if the patient comes and you cath them and you find a tiny vessel in the RCA, like a tiny branch of the PDA, that you put in an ICD and you put in a stent, but the patient is having incessant VTs or the patient's ejection fraction is 30%. So it is not really explained purely by this closed small artery. Like even RCAs, they shouldn't drop your ejection fraction to 30%, 20%. So if you have something like that, then there might be a mixed picture of ischemic and non-ischemic, and that VT might come back and haunt you and might kill the patient.
What scares you more, AFib, post-acute sedation, or
No, AFibs are they're there to stay. The VT may go away, but the AFibs, they're very strokey. Would people rather die or get a stroke? I think most people would rather die.
Do you think we'll ever get life vests here?
I wish. I tried. I asked them. It's $60,000. So LifeVest is a fantastic bridge from during this time between the STEMI and between 3 months after when you want to reevaluate the ejection fraction. LifeVest is fantastic. It saved one of my patients. So in the US, there's something called the LifeVest. The LifeVest, where you wear the vest, and this works as an ICD, exactly an ICD. And then after the 3 months, if your ejection fraction gets better, or you get an ICD, and then you return the LifeVest. But it's very expensive. It's a rental, yes. If somebody wants, if one of the companies wants to invest in LifeVest, then it would be good in the interim where you wait the three months. It's not recommended for non-ischemic myopathy, but I had one patient that I actually placed the LifeVest because my nurse insisted that I place on the LifeVest, and she did have sustained VT, and the LifeVest saved her life.
Questions from the audience there?
Dr. Ahmed Al-Khlafi. I do have a question about the refractory VTACs and VFibs. What is the role of double sequential defibrillation? Is there clear guidelines, recommendation for using it, whether you're using it in acute cardiac arrest or in refractory VTAC or VFib?
I'm not sure I get your question.
So the double sequential defibrillation.
Okay.
Is there a role for it, like clear recommendations or guidelines, whether we're using it in acute settings or in cardiac arrest for refractory VTACs and VFibs?
I mean, if somebody has an intractable VT, incessant VT, you just shock. I don't know, whichever is available for you, available in your institution. You just don't want to miss a VT and the patient will die. Sometimes in larger patients, you can have 2 devices at the same time, and where we have 4 pads on the patient, and then you just like shock. But you don't see it much in Jordan because we don't have the morbid obesity that the United States has. But in the US, we had somebody who was like 800 pounds, which is 300 kilo. And literally, they needed 10 people to carry them to the hospital, and they're huge. And the amount of subcutaneous tissue is this much. That patient needed an ICD, but we had to put 2 devices at the same time and shock him to get them out of it. And I couldn't implant the ICD because the table couldn't hold him, so we had to go to the zoo, and he had to be implanted at the zoo. So, I mean, but I digressed from the main point. But the point is, sometimes you just have to use what you have. Yes.
So, Mohammed, back again to the question of VTAC post-MI. Third day VTAC is going to be treated immediately, right?
Correct, with an ICD. So one of the ways the red flag for me is that if somebody has an inferior STEMI, the inferior wall is very arrhythmogenic, and a lot of the patients who die from VTs a year or 2 years later is because of their after the inferior MI, they die of VT. And the whole idea about the normal ejection fraction is that it doesn't prevent a VT, but it's able to get you out of the VT. So usually, if you have a VT and your ejection fraction is 60%, usually, not all the time, usually if you go into VT, the heart is able to terminate the VT. But when your ejection fraction is lower, your blood pressure drops, everything, and the patient's can do poorly. So it is, if you feel VT is a main cause, is one of the major causes of sudden death in ischemic patients after MI, a year after MI. And these people, it's very difficult to know which ones are going to die and which ones are not. But generally, if you have a low ejection fraction, I would keep a high suspicion, just Holters. If you see VTs, there's good place for EP studies, which is basically, it's a half an hour study. If you see VTs, half an hour study, you put a wire in the right ventricle, and then you stimulate, you give some isoproterenol, and if you go into sustained VT, then you can you place an ICD. So these are the patients that don't really follow. These are the gray zone. The gray zone. Thank you.
Thank you very much. We are leaving the stage and we'll advise that we will do our meeting.
Thank you. يعطيكم العافية جميعا. Thank you so much. I know it's been a long haul. Hopefully everyone يعني استفادوا or made use of it. Was a good session. Just to kind of recap today's what have we learned? شو تعلمنا? Multiple things. أول شيء there is no يعني good substitute for good collaboration or partnership. Second thing is we all agree, from the beginning of the day that the journey of care does not stop in the hospital. You have to look at the patient down the road and treat and prevent disease. Also, we need to recognize the disease early, educate patients, educate the population, educate the healthcare physicians about chest pain or risk factors. We do want to get to a unified pathway. There are different biomarkers. Each one has its minute things and minute approaches, so we need to pay attention to that. Also, different inpatient treatment methods, whether we're talking about primary invasive or pharmaco-invasive, post-ACS care, and the importance of cardiac rehab. We've spoken about different experiences like the American Heart Association. We've spoken about also ACS complications, and of course we appreciate the Difa al-Madani. But now, what are the challenges that we want to tackle and put recommendations so we can take it further, inshallah, for roundtable discussion and down the road to policymakers. Number one, I think there is underestimation of the disease. So we need to pick up, diagnose early, we treat early. Number one. Number two, there are different resources or different care systems that we need to get together, working together better, or on the same playing field. We need to get PCI more available everywhere because we all agree that the major and the best way to treat a STEMI and even acute coronary syndrome is PCI. So we have to find a way to get PCI available to more people. And if we cannot do that, and if PCI is not available, then we should not forget lytics. For the patient to stay in the hospital with a STEMI and not have anything treated is horrible. Also, maybe we could get high sensitivity cardiac troponins available everywhere or more widespread. That would be a good thing. We've all touched base on how important ECG to be done very quickly in 10 minutes. And also we spoke about how efficient transport is important. And efficient transport is not just from home to hospital, it's also from hospital to hospital. Medication compliance, and from the patient standpoint, and physician compliance with the guidelines is also from another point. So what recommendations can we do? Number one, we're going to need to invest in partnership. We have to work on this, us as Jama'at al-Qalb, all of us in different areas and different positions. We have to start making more partnerships so we can work together, especially between the public-private partnership. Second thing, we're going to put a good unified pathway, maybe even printed in a booklet, distributed, have posters available in all ERs of the pathway that we agree on. We need to educate and increase awareness both in the population and healthcare physicians. We need to train and also create a PCI network. Ultimately, we also need to work on the future. We need to create registries for research. We need to have quality metrics. We need to assess how good of a job are we doing. We need to audit ourselves in a sense. And we've also spoken about maybe doing a campaign on BLS and AED. That would be great. And ultimately, also about cardiac rehab. We need to think about creating centers in cardiac rehab. Finally, I will finish in one word that I started with: collaboration, collaboration, collaboration. Thank you so much, guys. Round table.